Hello, the doctor is in.
Smile. Looks to me like we are live. Good evening, everybody.
Good evening. Hey, Monique.
Hey, Ricky, how you doing?
I am great. It's a beautiful day here today, and we have a great show. We have a great show planned.
I'm very excited about it. Absolutely.
Thank you.
All righty.
So today we have some really special people, Dr. Mo. We have Quita Highsmith from Genentech, and we have Nicole. Nicole, how do you pronounce your name? Edgel, right?
Yeah, Edgel.
Our new breastie. So why don't we start by doing some introductions? Dr. Mo, do you want to introduce our fantabulous Quita person who's awesome?
I do. I absolutely do. Give me 2 seconds. There we go. So this is super exciting for me, but I am so pleased to introduce Quita Highsmith, who is the Vice President and Chief Diversity Officer at Genentech. And she's a member, this is a member of the Roche Group, and she is a leader with almost 3 decades of experience. Holy cow.
Right. And she's not old, and she's not that
Black
old.
don't crack.
Not even close. Not even close. Oh my goodness. Talk about the black that doesn't crack, right? But, you know, her area of expertise is in oncology disparities, and she said publications in the Journal of Oncology Practice, the AACR, Contemporary Clinical Trials, you name it. And she is responsible for leading Genentech's diversity and inclusion strategy. So that includes recruiting, that includes retaining, developing diverse talent, meeting the different initiatives, setting those initiatives, supporting science education, addressing barriers in clinical trials. And this is the drum that we have been beating and will continue to beat throughout the month of October, throughout 2020 and into 2021. We have got to talk about clinical trial participation and advancing inclusive research. So I could go on about the award-winning visionary that she is. In 2020, she was named one of the 100 most influential women in the business in the Bay Area, in the San Francisco Bay. Pharma Voice Women of Influence list. She is a member of Delta Sigma Theta Sorority Incorporated and is a member of the I love it. The Delta San Francisco Peninsula Foundation Board, which provides scholarships for Black students. She has an MBA from, of all places, Cornell, and an undergraduate degree from University of Kentucky. You can tell us more about the Q family, the Q crew. And I'm just so excited and pleased to have you here because I have heard about you through so many different sources, and it's amazing how small the world is and how connected we all truly are. But it's so nice to have you in our Zoom and our living rooms today. So Quita, thank you for joining us.
Thank you, Ricky and Dr. Monique, for inviting me.
Thank you. And you know what? I really want Q to talk about how she got her job that she has right now. But let's introduce Nicole and then come back to that. So Nicole is my breastie. She's our breastie, and she's a newbie breastie, and she's actually a doctor too. She's a veterinarian.
Yes.
So she spent the last half an hour talking about the bad foods I've been feeding my dog.
Uh-oh.
We're getting ready for the show. Like my dog was eating those white donuts with the sugar on them, Terry and my dog.
Ricky, don't do it.
I know. And she's already had ice cream today, a few chocolate cookies, but she survives me. So, but Nicole's going to share her amazing story that will kind of support some of the data that Quita's going to talk to us about. But Quita, tell us how you got your job and like how God worked in your life right now.
All right. Well, again, thank you, Ricky and Dr. Monique, for having me. I'm Quita Highsmith, Vice President and Chief Diversity Officer at Genentech. And for those who don't know, Genentech is considered the founder of the biotech industry. 43 years ago, we have about 13,000 employees, and we seek to discover medicines to treat patients with serious and life-threatening medical conditions, including oncology, multiple sclerosis, lupus, and neuroscience, and ophthalmology. And I have always been on the commercial side of the business, whether it was leading sales forces, marketing franchises, or most recently, I was in government affairs, leading patient advocacy. So I never thought that I would actually be doing the official job in diversity and inclusion. But about a few years ago, another lady and I at Genentech, we realized we were setting up a patient summit. And I wanted to have patients that were people of color that had participated in the clinical research. and we could not find anyone that
Wow.
was a Hispanic or Black person that had participated in clinical research. We started to ask the question, why? And what we found out is that 90% of the clinical trials are done on people of European ancestry, basically on white people. And so we set about starting an initiative at the company called Advancing Inclusive Research, where we wanted to really think about how do we diversify our clinical studies so they are more reflective of real world patient populations. And so fast forward, that work really resonated within the organization. And when it was time to name a chief diversity officer, because I was able to really galvanize our entire organization around inclusive research, I was asked to come forward for the role. And here I am, took that job on January 1st, 2020. And what a ride it has been, because certainly, and during that time, we did not have a pandemic. We were not sheltering in place. While we may have realized there were racial tensions, the rest of the world didn't need to pay attention because they were going to dinner, they were going to the movies, they were on flights, they were on vacation. But the pandemic and George Floyd's death caused people to wake up and really understand what many of us have known all this time. And so it's been a really interesting journey, and I'm super excited about, the opportunities that we have ahead of us.
That's great. Well, also that job didn't exist before you.
It did not.
Right. That's what I'm trying to get you to, girlfriend, that
That's so incredible.
you made the job happen based on the work that you were doing. And you said, hold on a minute, we need to be addressing diversity and inclusion. Hello. So thank you.
This is what's happening though, all across the country. I think Black and brown people are being called upon more and more to participate in these committees, to form these committees, to sort of provide some structure and some organization to the D&I efforts that our employers are trying to develop. But I love this as an example of the possibilities. Because
right.
It can be a frustrating and a very thankless job where you feel sort of put upon. Now all of a sudden, because you're the one brown person, you are now on the committee. You are actually maybe chairing the committee. You're shouldering
the You are the committee, right.
You are the committee, right. Speaking from my own experience, but there can be opportunities. Every challenge is an opportunity. And I love that you were able to do that. And here you are now, front and center.
Front and center.
This year. Yeah. Spotlights on you and on your initiatives and on your research. And I think it's incredible.
It's your party.
And the other thing is, when I came into the role, I think diversity and inclusion, people think about it as far as representation only, right? And I think we have to think more broadly, because when you focus on representation, what happens is people are resistant because they trying to take my seat. Right. And people feel like there's only so many seats around the table instead of thinking very broadly about diversity and inclusion. So of course, we have three pillars. One is about fostering belonging, and we want to create an environment where people feel like they can bring their true selves to work. So, I'll give an example of that. Last year, I cut my relaxer off after all these years of going to the hairdresser every Saturday, and I got tired of that. And I cut my hair and I was like, I'm just going to go with the natural. And a part of me said, will I be accepted by the organization for going natural? And because people sometimes have to code switch, right? And they can't bring their true selves to work. And I think when you can't bring your true self to work and you're thinking about, did I dress right? Did I say this right? Do I'm looking right? You use the mind space that you could be using to address the problems and solve them.
Right. Do the work. Right.
To do the work, but you got 60% there because you're like, well, I got to look a certain way, I got to sound a certain way, I got to be a certain way. I kind of gave up being the Queen of England a long time ago, so I have been myself. But we want to make sure we have an environment where people can feel like they belong. Then, as we initially kind of talked about, we really have to advance inclusive research. We really have to make sure that everyone has access to the medicines, access to clinical trials, especially in oncology, because in oncology clinical trials, that's some of the best care you're going to get. So we want to make sure that it's equitable. And then
Right,
the third
right.
pillar.
That's interesting. you
Wait, say
said
that again. Say that again.
The
'Cause I
best
didn't
care
hear
you're gonna
you.
get. I'm writing it
For the
down.
people in the back and the
For the
chief.
people in
Right,
the back,
right,
you
right.
need to be in the oncology clinical trials. And then for us, the third area is how do we think about transforming society? Meaning that we take our vast resources and we invest and we partner in healthcare. We think about who we spend our money with. And we also think about the long game, about the pipeline for us. That means scientists and doctors. And how do we use our resources to help build and support the pipeline for positive change?
I love that.
I love it.
Sounds like a
Awesome.
really
Awesome.
comprehensive 360 perspective, because that's so often what's needed is
Right,
that we
right.
fill in part of the pipeline, right? We'll go to the undergraduate schools and we'll cull the talent, right? But then
Right.
we raise the researchers, but the gap between the research and the bench and the patients is missing, and it's the clinicians, right? You
Right.
know, and so focusing on each area of that is just, it's huge. And I love that you said you got to bring your whole self into the room. And it resonates with me because I talked to students just last week and they had a diversity fair for medical students. And I said, if I leave any part of myself outside, then I'm not able to effectively use my voice. I will always be thinking about the part of me that can't be there. So, you know, in my hospital, I'm the only Black surgeon on staff, the only female surgeon on staff, the only LGBTQ community member on all the things. And if I leave any of those things out in the hall, guess what? You're not getting all of me, right? And I'm not able to do the most
Right. Do the
effective job.
best work.
So
Right.
that's something that people, we are so afraid of that. We are so afraid.
And we shouldn't be. We shouldn't have to
There's
be.
no
We shouldn't
time.
have to be. No, we
No
don't have
time.
time. We don't have time.
No time.
So Quita, you guys just did this huge study. Can you tell us a little bit about the study and what the outcome was, and then we'll get Nicole to kind of tell her story, because I think it's going to illustrate some of the things that you found.
You know, I think one of the things that is important to understand, why are communities of color not participating in clinical research? And I think there are a number of reasons. One, I think Dr. Monique said, we've got to make sure we have the bench. We've got to make sure we've got Black and Hispanic investigators, right? Because people trust people who are kind of in the same family. So if a Black investigator asks a patient, you know, Mrs. Jones, are you interested in participating in clinical research? They're more likely to pay attention. But what we also know is that Black and Hispanic patients are often not asked. And one of the things that we wanted to understand from the patients themselves is, what do they think about the healthcare system? So this summer, we fielded a survey of over 2,000 patients, and we looked at what we call medically disenfranchised versus the general population. So
what does that mean? What does that mean? What is medically
disenfranchised? Yeah, medically. So the general population is just like the regular people.
Right.
Then medically disenfranchised is, we looked at 300 LGBTQ, 300 Black, 300 Hispanic, and 300 low socioeconomic status, and that is people who made under $35,000. So we asked them a series of questions, and what we found out from the Black, Hispanic, the low socioeconomic status, the LGBTQ, is that 1 in 3 of them are not going to participate in clinical trials, get vaccinated, or get tested for medical conditions because they lack trust in the system. And what they said was that they believe that the system is unfair, that the system actually, based on their race, based on their ethnicity, based on their gender, based on their sexual orientation, based on how much money they made, that the system was actually rigged against them. And for these participants, that's hindering optimal care if you can't trust the system. And what they also said to us was that they don't feel like when they do go get care, that the healthcare system is considerate of who they are, that they are empathetic with them, and that their specific needs will actually be met. And it correlates to a study that I read a few years ago when we first started out on advancing inclusive research. I think it was from Jefferson in Philadelphia, and I might be wrong, is that it was saying that Black patients don't even get touched as much as white patients. They don't get pain medication. Their pain is not taken seriously. Their symptoms are not taken seriously. And we've seen celebrities such as Beyonce and Serena Williams say that when they were having their children, they were having complications, and they have all the money in the world, all the celebrity in the world, and yet they still had significant complications. And so that tells us that Black and brown patients may not be getting the same treatment and the same opportunities.
I think
Right.
we have seen that also with respect to, and that might have been Edith Mitchell's work out of Jefferson, but when you talk about, where patients get their care and having access versus utilizing the access, even in cities like Boston, where Dana-Farber is, you got MGH, right? And so 2 to 3 in 4 white cancer patients will go to Dana-Farber. 1 in 4, 1 in 5 Black patients will go, and the other 4 will go to their community hospital because the doctors look like them, because they feel like they're going to get more personalized care. They feel like they're addressing the person. They're not going to be disrespected. They're not going to be ignored. And so I have questions for you though, because my number one question is, when you say the system, are you then able to, or could some corollary studies maybe pare down what people mean when they say the system? Do they mean the administration? Do they mean the nurse? Do they mean the doctor? Do they mean, where are those areas where patients are feeling alienated, feeling disrespected? Because I think those are going to be some key places for intervention, because that's where we got to go. When you look at medical students, between the first and second year of medical school, there are biases that are introduced by their mentors. And because I do a lot of DEI work for medical schools, and that's where it starts. Even between the first and the second year, you could do a survey of the first year students. What do you think about Black patients? What do you think about this? What do you think about brown? What do you think about whether or not their skin is thicker or their pain scores are the same? And between the first 2 years of training, there's a difference. The biases are starting to develop already.
I think it's the whole continuum, right? It is, like, especially, I think if you think about some of these Ivy institutions, it's scary just to drive up to the Ivy institution. It's, fancy institution where you got to figure out the parking, and then they are, people are judging when you come into the front door, how you look, what are you wearing? We had did some other research, and some of the physicians had said that, like, if the patient has an iWatch, or they have an iPhone, then I'm more likely to ask them to participate in clinical research versus somebody who doesn't. What does that have to do with it?
Wow.
Right. And so
I call it Emerald City. My patients have to go down to Emerald City for certain trials. It's like going to see the wizard, right? But that's where the research happens. That's where the funding is. That's where the projects are. So what do we do?
That's what we have to change. We have to change to make sure that we're in the community. And one example that I will share with you, as we all know, COVID has disproportionately impacted communities of color for a whole host of reasons, right? We have to work. So we on the front lines. We might not live in the place where medical access is readily available to us.
Right.
And so a whole host of things. One of the things that we've done is we've just completed a study and got positive results called Impacta, where we looked at over 389 patients with COVID-19 pneumonia, and it read out positive that they had less chance to go to mechanical ventilator. But here's the beautiful thing. 89% of the people, 87% of the people in the study were from communities of color. And yes, so it could be the first COVID study that actually has that high of a number of Hispanics, Blacks. We even went to Navajo Nation. We went to Kenya, to Peru, Brazil, Mexico, because we need to understand, how does our products work in communities of color? Is this safe and effective? And one of the reasons that the program was successful is because we went to institutions that were in the community, where you driving by every day in Jamaica, Queens, where you driving by every day in Detroit, where you driving by every day in Miami, versus going up to the Ivy Tower. That's how we build trust. You got to go to where the people
be there,
are.
where the people are. Yep.
Yes.
That's
Yeah,
right.
yeah. Wow.
Can I add,
Oh,
can I
jump
say-
in.
Nicole, what's up with that? Tell us your story, girl.
Well, for me, I was diagnosed with breast cancer in October 2019. And, I'm a veterinarian. So medically, we deal with breast cancer too in animals. But to get that diagnosis for myself, I felt completely lost because what does that mean for me as a human being? And my OBGYN actually told me that, hey, you have breast cancer over the phone. And then she went on to say it's triple negative. Now for me, I'm like, triple negative, is that good? Is that bad? What does that mean?
Right. I said that doesn't sound so bad when I heard it, right?
The horrible thing
Sounds
is
like
I
three
have
strikes.
breast cancer. Oh, my life is shattered right now. But triple negative, does that mean good? And so I was totally in a little bit of a panic, because then her next thing is, you need to go find a breast surgeon. And for me, it took me back, because my first thought of hearing such notice of that, of getting cancer, is, am I going to die?
Right.
The second thing is my kids. At the time, I had a 9-month-old and I was holding her. So I felt completely alone, abandoned, lost, because I'm like, what do I do with that information? And for me, because I do have certain colleagues and friends who are doctors, human physicians, and one in particular, her sister, I didn't know it at the time, is a breast surgeon. So God definitely placed people at the right time in your life for a reason and a purpose. And that was definitely the purpose, because she was able to help me find a breast surgeon here in my area where I live. And by finding that one, the things started to come too, but I wasn't helped. No one helped guide me at all. And so that happened to me, and I am a doctor too. I work with animals, of course, but I'm a doctor, and I am still getting that type of treatment. So it doesn't matter, the degrees, it doesn't matter the status quo. When you look like this, and you are a female, for some odd reason, they're like, okay, you deal with that, and I always question, if I was of a different ethnicity, would I have been guided like, ma'am, I need you to come into the office. This is the information here. This is who you need to call. This is, what I'm saying?
Absolutely.
And I didn't get that. And then it just got more deplorable, to be honest, because my oncologist at the time, he's the chief of staff in my area. He's the chief of staff of the Cancer Institute. So when his orders weren't pushed through for my chemotherapy drugs, the correct orders, and so when I'm getting chemo, I'm about to get the wrong chemo that could kill me, okay? Because I do have a medical background, I'm always knowledgeable to ask these questions before I go up. What chemo am I getting, and what's the dosage? Some people don't want to know all that because it's too much for them to know, but it's important, because when you show up, had I not known what type of chemo, at least that, what type of chemo medication drug, the name that I was getting, Plaxitaxel and carboplatin, if I didn't know those two, that I was not supposed to get the Plaxitaxel anymore, I was supposed to get the Taxotere, I would have had a cardiovascular event and I wouldn't be here to this day. And I had to challenge the nurse and the physician assistant to say, you're wrong, read my oncologist's medical notes, because that's not what he told me on my last visit. I do not get that type of medication. I would not be here. So, I mean, the list goes on and on and on.
Keep going,
And
keep going.
So much.
What you said.
Well,
If you want me to go.
No, keep going. I want you to say that what you said before the show started. You said, I got labeled. Talk about.
No, I did. I got labeled as difficult.
What?
Difficult, because I was asking questions. I was making them accountable. I was telling them that this is unacceptable. And I was telling them, especially when they were going to give me the wrong chemo, okay, that you're wrong. Please check with my oncologist. No, I think you're sadly mistaken, ma'am. I think you're sadly mistaken. No, I'm not. I'm clear. You're wrong. Please call him. And if you don't get in touch with him, check his medical notes. Any
Yeah,
doctor,
read the chart.
any
Right.
doctor that is professional has medical notes. That's by law. I know for me as a veterinarian, it's by law. You're supposed to have medical notes. So if you change a dose, if you have a treatment plan for a patient, it's there in the medical notes. So by me being adamant and standing up for myself, and that's why I say it's the voice, it really made me alarmed because there's so many people who suffer in silence and they get passed around or they get looked over. You know, there was a period of time in my cancer journey, right at the beginning of chemo, where my blood work was inaccurate. It wasn't inaccurate because of some type of misplacement of my lab work. No, it was inaccurate because their machine equipment was faulty. Because they weren't checking and doing the daily whatever analysis that they need to do with their machine, that my white count was low. So literally for a month, I did not get chemo with having triple negative breast cancer. 1 month, because every week I would come back, they would say, no, your white count is low, your ANC is low. And to some people, they're like, ANC, I had to ask them specifically, white count. When you say white count, what specific white count is low?
Right.
Because they're looking at your neutrophils. And so these are the things that, you know, I wouldn't have known if I wasn't medically trained. And the other thing that I got was, what do you do for a living? You know, when I ask these questions, because I don't lead. I do not lead.
Oh my.
Love it. Yep.
What do you do for a living? That's when I say, well, I am a veterinarian. Oh, impressive. You know?
The dialogue changes, doesn't it? Even when I go to an emergency department, which is infrequent because I hate doctors, but when I go to a hospital, I don't tell people what I do. Because I want to see how they will treat me. And I know that, you know, many of our family members have the opposite. They try to humanize their loved ones because they know in that moment they may not be believed. They may be mistaken for drug seeking. They may be a lot of things. Right. And as soon as you say, no, she's a professor. No, she's a business person. No, she has a degree from Cornell. The dialogue changes, you know, the approach, everything changes. And I hate that we have to qualify ourselves in this day and age. We still have to qualify ourselves just to be seen in the light of intelligence, intellect, and worthy of an explanation.
But just think about it, you guys. What if Nicole didn't have not only the knowledge, but also the self-advocacy to talk about herself? She would be dead. How many people die because of what she went through? How many people die because of what she went through?
How many of the 30,000 people that are watching right now don't know what an ANC is? They're still trying to wrap their head around what an ER and a PR and a HER2 is.
Right.
You know, and don't have that voice or that they don't even know what questions to ask.
Well, which is why programs like this are so important, right? Because, you know, in the Black community, we don't always talk about our health, right?
No, we don't. We don't.
Health.
Keep that quiet. And then we finally get to the doctor and it might be too late, right? And so that's why these kind of venues are just so critical for us to get people to, you know, speak up and to hear these stories that Nicole is just sharing, because if we are not advocates for our healthcare, no one's going to be our advocate. So we need to be the person who is difficult, because I'm trying to live.
That's
right. Hello.
Squeaky wheel gets the grease. And isn't that what your data show, Quita? Can you tell us the outcomes there?
Yeah, exactly. So all of this is, you know, what we found. But I also want to go just thinking about just in general the data and why it is so important for us to participate, right? When we know that 40% of the mortality rates in breast cancer are Black women, but yet only 6% of Black women are included in the clinical research.
Right.
And so our opportunity is to talk to our communities, because you know what, there's a lot of historical issues, you know, Tuskegee.
In current context.
Henrietta Lacks, yeah.
Right. So we do have to explain why this is important and what safeguards have been put in place today, so those same things won't happen. But what is one area that is very concerning is the genomic material. Back in 2016, 81% of the genomic material that was collected was people of European ancestry. Fast forward to right now, it's 90%. And what that means is artificial intelligence, which is making algorithms for treatment decisions for women with breast cancer. The algorithm that is feeding the information is based on white material. And so the algorithm, it might be spitting out stuff that is not relevant for us because it might not understand ANC. White blood cell count might be different. Creatinine clearance might be different. All those things that make us unique and special are probably not included. And more hospitals and companies are using algorithm based on this genomic material that is not inclusive. And it's really a concern that I have, which is why I wanted to participate, to encourage, if you have the patients who are out there, to please allow them to collect genomic material so that we can use it in our studies.
Absolutely. I think we are seeing the same thing in trends in imaging. So mammography is utilizing artificial intelligence, and where the trials and where the data and where the algorithms are not inclusive of Black women, we find that the risk is skewed because these machines will now spit out a percentage of risk for patients. So that should be more accurate than Tyrer-Cuzick and Gale models, and all the risk models that calculate what your percentage of risk is for cancer are based upon things like your age, your BMI, which again is a European ideal body weight, right?
Exactly.
Your bone density, right? Your density of your breast. And so if it's not calibrated and validated on Black women, then these models are off and they are underestimating the rate and the risk of cancer in Black women. And so we see this now, and whether or not it's by design or not, it is what it is. It exists. And so we need Black women to participate even in imaging trials so that we can validate the artificial intelligence on their breast density.
How do we do that? How do we do that, Quita and Dr. Mo? How do we get people to do that? I mean, we talked a little bit about genomics last week, but for people who weren't watching, can you explain genomics a little bit, Dr. Mo, just so people understand what that means?
Oh, I was gonna let Quita do it because
okay.
I'm the expert. I'm up here. I'm you the expert.
I know I absolutely can and will. So genomics is the study that looks at your tumor's biology. It looks at the factors, not just the receptors or the factors on top of the cells, but it looks at the actual genetic material to understand which genes are turned on, turned off, to what degree they're turned on or off. I call them like the bat signals or the flare. Yeah. And so, when I talk to patients about the difference between, say, their hormone receptors versus their genomics, it's like if you're driving through a neighborhood looking for a house. And you're looking, you say, oh, this is lovely colonial, look at the blue shutters, oh, I like the lawn, you like the features of that house. Those are the hormone receptors. But then when you talk about how the house was designed, the blueprint of the house, that's the genomics. And so it gets to the blueprint of these cells and what it's telling your body to do with respect to metastasis and recurrence, all those things. So it's your DNA, it's your material, so that we can understand how aggressive a tumor is and how your body will respond to the different therapies.
I'll give a kind of an example. This, when we were all traveling before, and could the clear, right? You could go to the airport, you can do the clear.
Right.
You have to give your eye scan, a fingerprint. And my husband was like, no, I'm not giving the government my eye scan, my fingerprint. So I was like, well, I'm going to do it. And you could wait in the long line and I'm going to just fast forward and jump on forward. So he did that a couple of times. I went on quickly through. And then he realized the value of the participation, right? That you are going to have more opportunity if you participate in ensuring that, they are doing the right sequencing on you. And so, people are afraid though, that if they give up too much of their personal information, that somehow, that's going to come back and have a bad result, right? But
then they do it anyway on 23andMe, right? And color and ancestry, that data is not protected.
Yeah, no, it's not.
And people are spitting in tubes and sending it off, and you don't know what's going to happen with that data.
Right.
So if you want your health to be better, it's better to participate.
Yeah. Can I say something from a patient perspective?
Yeah.
Research was offered to me And I definitely participated in a couple. There was quite a bit of them. The problem, though, to be honest, I felt is that the presentation wasn't good. It was, we have a research, want to know if you're interested, someone's going to come in and talk to you. And this person really didn't have medical training. It wasn't the nurse, it wasn't the doctor, it was whoever was behind getting people signed up for the research. So
The coordinator.
right, the coordinator, there you go. So the problem was when I had specific questions medically, she couldn't answer it. And she was like, oh, you may need to talk to Dr. So-and-so about that or whatever. The problem is that she said, but here is the information. It's a lot. And so for the average person that's not used to some of those medical terms and jargon, lingo, it's overwhelming because it's already the process of what they're going through is overwhelming. And it puts, and to be honest, there's fear. Because even for me, I'm like, oh, you want a piece of my breast tissue? You want my DNA? Like, oh, okay. And what is this vaccine for? Like, so it put me in, even for me, in a state of fear. And so I think that's what a lot of people are driven by, to where there's the unknown. Yeah. And then there's all this information that they don't know how to decipher through. And so then they're just like, no, I don't want to.
And you're so vulnerable. You're really so vulnerable. You're already vulnerable because you're sick, right? And at least, Nicole, you're a doctor, so you have so much more knowledge than the average person. When you're raw. You're raw. You don't know what to do. You're in this situation where you know nothing, and you feel totally out of control. And as Black women, we do not like to be out of control. We are all control freaks, right? Helicopter mom, helicopter grandma, hello. But
personality.
Yes, but when you strip away all of our control and we're sitting there raw, and then you want to stick a needle in my arm and you can't even tell me what it's going to do. I don't know about that.
But the promise of personalized medicine, though, is that we would be able to tailor therapies to be less and less toxic. And this is one of the things I tell patients, we can't personalize your medicine to a genome we don't have.
Right.
We don't know it. You can't get the tailored down, more personalized approach. But my question for you, breasties, for you two, and anybody else who can type in the chat is, when is the optimal time? What is the best way to do this? Because you're absolutely right. Like this, you just got a diagnosis, you're wrapping your head around, you're trying to figure out, do I need to take leave from my job? What's my insurance going to do? What about that vacation?
What's going to happen to my kids? What about my kids?
Right. And all the people who are dependent on you, right? So when is the time? What is the way? And how could that have been different or better for you?
I think, can I speak real quick? I think for me, it would have been good. Because like when you're first diagnosed with breast cancer, everything goes warp speed, You have to do all these tests and everything, and you're still trying to wrap your head around, I have cancer, And so it's a very dark place because your emotions are everywhere and you don't really have time to really sit in your emotions to figure out what just happened to my life right now. There's a period of time that you have usually, in most cases, I know what I did with triple negative, after you're done with chemo, before you have your surgery, your breast surgery. I think that is the time where you kind of sit in your thoughts a little bit. You're healing from chemo and you're preparing yourself mentally and emotionally for the biggest change of your life,
Right.
Whether you have a mastectomy. And so for me, I felt like the information probably would have been better at that time. So it could have prepared me, because when I went for my surgery, then that's when it was presented. Hey, we have everything for surgery, and here's this study, and here's this. It was too much information at that moment.
Way too much. Way too much.
And so you're right now focused on this major life-changing event, and you really can't decipher through all the, studies, and then at the same token, after, they also talked to me a little bit about a study, but after the fact, I think it was lymphedema study, but after having, for me, I had a double mastectomy.
Right.
I had 5 drains out of my chest.
I had 8. They suck.
woof, you know, I thought mine was bad, Ricky. Yes, I had 5. And so I was like, no, I don't want to hear about any study right now. Like, I'm in excruciating pain, and I'm still trying to wrap my head around about who I am at this moment, you know, because you change through this
You know,
process.
did you get the cancer out? Is it in my? I remember.
Thank you.
When I
am
looked,
I going to get a pathologically good response? You know?
Exactly. Well, when
That's what I want to know.
I remember when I woke up from my surgery, and you wake up and you feel like a truck drove through your body, backed up and drove through again, right? And then so you're in this like pain like you never felt before. And I had 8 strange because I had 7 out of 10 lymph nodes taken out. But the first thing you ask is, okay, well, did you get it?
Yeah.
And was it in my lymph nodes, right?
Yeah.
And like, how bad is it? Like, like you're so worried about that to talk about a trial, like what? Like not at that moment. That is not the moment.
Let me
You
jump
can't
in
even.
again. Let me jump in again. I got to keep paring this down and teasing away at this because I need to understand where are the entry points. So what I heard you say, Doc, is I heard you say you need a better psychosocial support up front. Is that accurate?
Yes,
Because if
she
you
had
could
no
have
support.
wrapped your head around what was happening, you might have been receptive to something else, to even having a different conversation. But you were so unable, you just didn't have the bandwidth because of feeling overwhelmed, right?
Right.
And so there are some trials though that need your information before your chemo. After chemo is too late. We need to talk to you before the chemo to see how you're going to respond. I need your tissues ahead of time. I need your consent beforehand. So, but one of the key things I just heard you say though, was that if you had maybe a better psychosocial support and a way to process this, you might have been more receptive. You think that's an accurate statement?
Yeah, no, I think that's accurate because, for me at the beginning, I was trying to figure out how to live. Like, I don't want to die. And then at the same token, trying to navigate who do I need to see, when do I need to see, and how, like trying to navigate. And then at the same token, understand the disease. I never before in my life heard about triple negative breast cancer. I didn't know what that was. And then when I Googled, I wanted to literally shut down the internet, like close it down, because it was just like, oh my God, I have the worst form.
It was all negative. It was all negative. All negative. Everything was bad.
Yeah. And
you're going to die. You're going to die.
So better explanation.
Thank you. It's just going to reoccur. Yeah. So it was just doomsday. And I had at that time a 3-year-old and a 10-month-old. She just turned 10 months. So it's like, yeah, absolutely. And the sad thing is I'm not alone. There's probably people listening to this who can resonate, I hope, with this, and just to let them know you're not alone. And so we got to find a way to do better, because I think people suffer in silence. They just accept that this is how it is. And by that, they're on antidepressants and everything else, and then barely living, trying to live, but can't because they're stuck, and then they miss opportunities. They don't know where to go. They don't know the foundations. There's the foundation for everything. I mean, and that's something I had to learn, but you have to reach out, and to find it and to help with that guide,
And so many of us have extended family members and other support that are not our immediate family also, Quita, when you think about the LGBTQ community, your chosen family may not be your blood family. You may not live with those folks. You may have other issues that preclude you from even, getting screening. And there's all this guilt and there's all these emotions that are wrapped around this diagnosis. You may not know your family history, and so there's a lot, I think, to what you say, Nicole, in terms of maybe just having better support and maybe having somebody else who had been through it before, pairing more of a, not just so much the navigation, because it's great. Okay, you have a nurse who can help make appointments for you, but actually having a breastie who has gone through this process sort of paired with you to help guide you through questions.
Yeah, I actually had that. Thankfully I did. That's how God placed people in your life for a purpose and a reason. Because I have a good friend, Priscilla. She helped me navigate to Shovana, who, was going through her journey, triple negative to be exact, the same. So she was a guide. But the thing is that there's a standard of care that's not always standard of care, depending on your area. what she was given and what she went through. And thankfully, one of her good friends is a breast surgeon. You know, her name is Robin. You know, she was helpful to me down the road. But because of that connection and stuff, she knew certain things was supposed to be standard. For me, I didn't. And so there are times where, you know, you feel like you don't want to overburden, you know, someone with your mess. And like, even I reached out to Ricky. I was like, I'm drowning here. I'm out here in the middle of the ocean, you know, and in the dark with no life vest, no raft. And I feel like, am I going to die? I don't know where to go. And,
and she called us.
Place to be in.
Yeah, but you know what also too, you know, you feel like even when you have support, it's not always the right support. So that's why the breasty love thing is so important, because we can relate, because we get so many calls when, you know, the doctor said XYZ, but what do you think? And I'm not a doctor. I don't really know the answer, but I can give a hug that somebody else can't give, you know? But I think when you, to your question though, Monique, when if someone had told me, and you know, I was sick 9 years ago. So there are 3 things on Google about triple negative 9 years ago, and they all said you're going to die. But if someone had told me, you know what, Ricky, you have a very serious disease, and we're trying to understand it better. So here's what we're going to do for you. Here are the things that we can do. You can take these drugs that are kind of what we've been giving everybody, and sometimes they work, sometimes they don't work. Or you can try this other drug. And if I had been given power and empowered with information, I would have maybe thought about it differently. But it wasn't like, oh, here, try this, whatever. It's more about explaining the situation, saying, you know what? I don't know the answer. I'm a doctor, but I don't really know what's going to happen for you. You know, and I would say, well, wait a minute. Didn't you go to medical school? Like, you're supposed to know what you're talking about.
Make you feel confident?
No, but I mean, but in a way though, that makes me think that we can learn together, and I'm not going to hurt you. I'm going to give you something that's either going to, you know, be the standard of care that you would have gotten anyway. But if it was explained in a way that gave me power instead of made me feel vulnerable, it would have been a different conversation. Do you know what I mean? And I was never asked to be in a trial. I actually took carboplatin my second time around, which was still experimental for triple negative. But no one, they don't give you the time. You know, we got 7 minutes with the doctor, and they're so hell bent on what the routine is and what you're supposed to do and what you got to do. But, you know, boom, 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 boom. You can't, you walk out of there like, whoa.
Wow.
If you're talked to in a way that makes you feel like you're being helped and not being like sort of just in the way, the routine thing to do, maybe you'll think about it differently. And I think it's a power thing.
I mean, I can't get out of a room with a new cancer patient for under 35, 45 minutes, sometimes an hour, sometimes an hour and a half.
Well, you're a good doctor.
Until everybody understands what's going on. But what I heard you say was that, one, if you felt empowered, two, partnered with, right?
Right.
So Quita, I'm gonna bounce this question back to you. What are we doing to help educate researchers and or clinicians about how to approach patients about clinical trials? Is there room for industry to participate and help to do that and bridge that gap?
I think, first of all, what I'm hearing is that we've got to have more Black and Hispanic professionals in the field. That's
yes.
number one, right?
All the way, definitely.
It's going to be different.
Mm-hmm.
Right. When Dr. Monique says, I'm giving 30 minutes, sometimes an hour and a half, right? To ensure,
that's not happening.
Right. That's not happening. Right. And so first, we've got to encourage more of our young people to, go into science and medicine fields. It doesn't necessarily have to be an MD, but be a nurse, be a geneticist, right? So that's what we've got to get more of us in the room. And I think secondly is we've got to get more diverse people into research teams, right? Because then when you have the research coordinator who is a person of color, they're going to be more empathetic. That's what our studies show. People that look like them are going to be more empathetic in the situation versus you just, another number and you just Nicole and, I just got to get in here and get this information and get out, right? Because we know diverse teams drive better innovation and they improve outcomes. And I think the other thing is we need to see more Dr. Monique's, right? People
Right.
of color,
Yes.
more people of color, in
Yes.
more veterinarians, right? Because then it's like, well, I can be an epidemiologist, I can be a molecular biologist, I can be this and that because I saw somebody else.
Breast surgeon.
Right, I could be a breast surgeon. And so we're really thinking about a pathway that we're calling kindergarten to careers, where we're really focused on, because we know that systemic racism is a challenge from the very early days. And I am very concerned right now that COVID is going to put our kids back.
Yes.
If you don't have the technology and your family got one computer and everybody is being homeschooled and your internet is not good, is this a lost year for our children? And I hope it's not, but I am very concerned that it is. And so we're investing in the next generation. We're investing in PhDs, in postdocs, and in MDs, people of color. And we're going to various colleges and universities to put our money where our mouth is, so that we can build that pipeline, so that we can have more racially and gender diverse care teams. We have to do that.
Because there's one of me in the whole state of Pennsylvania right now.
See,
One, but 11 million people. Like, come on, we got to do better.
we
We
got
gotta
to
do better.
And part of it is it's costly, right? To go to get all that schooling, all that money you got to spend. We don't traditionally have that money. We get that money. We can't ask somebody to give us, all the money.
Can you pay for my medical school, right?
Right? Can you pay for my medical school?
My parents died. I'm an orphan, so I'll be working till I'm 90, but it's worth it.
Right. But because the systemic racism has not allowed us to take part in having the wealth and the money that we need to go further our education. We have to do that on our own.
Yeah.
I know, well, my goddaughter is a first year medical student at Morehouse. She just started, and so she just got the Bloomberg gift, and he gave this amazing gift to the college, but still in her pocket is $25,000. And not to say minimize the value of that $25,000, it's a godsend, but the tuition, I think it's probably like $250,000. So it's a drop, the drop in that little bucket. So I appreciate, I don't want to say it's a bad thing, it's a great thing, but more people need to be doing that. But the money that she's facing in loans and the amount of schooling she still has to get is crazy. The whole family's trying to, take care of her, help her out, because.
And when she finishes, she'll be another 10 years of earning less than her colleagues. So her overall earnings as a resident, as an intern, all those years, you still don't make, I think it came out to we did the math once, for all the hours we worked, we were making like $6.85 an hour as residents because of all the hours that we worked. And then when you finally finish, you've got to pay all of that back. And so it's challenging.
Find a better way to educate our kids.
And not only that, there aren't enough slots in residency. And we're getting off topic here, but as we talk about going into healthcare, there aren't enough slots for the number of schools that are pushing students through. Right? So you got the schools that are growing every year, more and more openings for more schools, but not enough residency and training programs for them, not enough post-bac programs, not enough postdoc programs, not enough of everything to get people into those careers and to fund them for their first couple of years of research, right? Like getting a training grant, a K01 or a T32, those grants are so hard to get. Quita, you wanted a career in research.
And I think we have to also educate our kids that even if you might not be an MD, you can maybe be a PhD, right? Like we have to educate about
right. There's lots of jobs.
What are the other opportunities that we still need people of color in the room so that we can make a difference? Because my daughter is a senior at Howard and she wants to be a geneticist. And so, we know that's she's planning to get a PhD, right? So we know that's going to be a long journey for us. And it's challenging, but we're going to have to make it work because we need her.
We need her.
Yes, we do.
We got to.
Yeah.
Right.
I love the support for the HBCUs.
Yeah.
Because I went to
I know.
Prairie View was my undergrad.
All right.
Yes.
Florida
And,
A&M over here, I'm a rattler.
Oh, okay. here we go.
Tuskegee, yeah, Tuskegee was where I went to get my veterinary medical degree.
Oh, nice.
Yeah, that's
I love
awesome.
it.
I know we have an HBCU intern program that we're doing right now too. So we have 5 interns that we're talking about breast cancer. But I just got to say one thing. This is kind of a little funny story. So I've had dogs my whole life, but when I got my new puppy, she's almost 2 now, I went to find a Black veterinarian because
It's like finding a needle in a haystack.
yeah, I know.
You might be the only Black veterinarian I've ever met.
I know, but I found one.
Oh, they're out here. Tuskegee
I-
puts out the largest
here.
number
No.
per year.
Yeah.
Tuskegee,
Yeah,
by
yeah.
far.
But I had to go. I mean, I wanted a Black dog for my doctor. So that's how important it is to having a Black doctor for my dog. That's how important it is when you get Black doctors. So I was looking for a Black doctor, and I found one. But yeah, we have a lot of work to do, and I think that your research is just validating
Yeah.
a lot of the information that we've always felt. That's one of the benefits of COVID too, that all this, these discrepancies that we've known for years are now on the table. But to put it in numbers and say over 50% of the people feel like the system is rigged,
I
it
guess
is
it's-
horrific. That is just unacceptable.
yeah.
Unacceptable. So
It hurts
I
my
mean,
heart.
Nicole just gave a
Hurt.
beautiful story. Like they were going to give her the wrong medicine.
right.
There you
Gonna give
go.
her- and what if she didn't
The
know what to do?
wrong.
What if she didn't know how to deal with that? Right.
Yeah.
What
And
if
that's
she
why
didn't stand up for herself.
What advice do we have for people who are watching? Because there are people who are watching from St. Croix. Somebody chimed in from like Scotland so far, or somewhere overseas. What advice do we have for people who are watching who might
Yeah.
be caregivers or newly diagnosed?
Can I start real fast
Yeah.
with
Go
that?
ahead.
For me, through my cancer journey, I would say you need to be informed about your own care. And if that means getting a recorder and asking, hey, can I record this conversation so you can listen to it later? Because to be honest, a lot of tears were streaming down my face and at the beginning of majority of my office visits. So the process of getting all that in my head was difficult. So having a recorder on your iPhone, pressing it, listen to it later. And if they don't want to do that, some medical professionals say, no, you can't do that. Then have somebody go with you so they can be the hand recorder for you, writing it down, taking a picture with the iPhone of the diagrams that they say, or the picture of the medication that they say they're going to put you on, because that's so important. Because like I said, I almost got the wrong chemo medication, which could have ended my life, literally, because I was allergic to it. And I already previously had a reaction to it. And had I said, no, that changed, I'm not on that anymore, and stood up for myself, I may not be here today. And the other thing is, to, like I said, to be informed, advocate yourself, but educate yourself and then act. If that doctor or the medical staff is deplorable, leave. And
Fire your doctor.
Yes,
your
I
doctor.
found 3. I went to 3 oncologists.
What's your insurance
3
isn't? That's right.
Thank
Yet
you.
again.
You can fire your
No.
doctor. Yeah.
Get your second or third opinion,
Yeah.
and be unapologetic about it, because at the end of the day, it's your life, not theirs, it's yours. And so you matter. And so that's what I would say to that. You may ruffle some feathers, but ruffle them.
Ruffle those feathers. Yeah. Yeah.
Wait, what you got for us?
All right. Well, I would say I think Nicole is right. Is right on as far as speak up. Right. I'm going to say 3 things. We need to speak up. We need to stand up, and we need to step up. Right. We need to speak to our family and friends and loved ones about participating in clinical research and asking questions about their health. We need to stand up and encourage the industry, the hospitals, the investigators, the policymakers, the Black churches to include
Sororities.
sororities.
Sigma Gamma Rho here.
Demand that we are involved. And then lastly, Dr. Monique just said the insurance companies. We need the insurance companies to step up, and employers and states and the federal government to make sure that people have medical coverage so that they can get the treatments that they need. Like, we have to create the future that we want, and we can't depend on others, which is why forums like this are so important to get the message out to communities about the value of taking their healthcare into their own hands.
I love that. And I'm going to echo what you said. When you talk about speak up, That means speaking up to your loved ones about your diagnosis, about your family history, having those really tough conversations instead of shouldering it alone, asking for help if you need it, and
Right.
asking for the type of help you need. You know,
Be
being
specific, be
about it, right?
specific,
What
be
it is that you
specific.
need, and maybe what's not so helpful. Maybe you don't need comfort food. Maybe you need a therapist. Maybe you need somebody to take the kids for a couple of hours so you can meditate and pray, or so you can talk to your therapist, or so you can, you know, spend time with your partner, right? So asking for what you need and speaking up if you don't understand something,
Right.
and not just doing this. And the doctor's talking and they got their hand on the doorknob and you walking out, you know, they're walking out the door and you don't understand a thing about what's going on with you. You know, so speaking up about that is so important, but also being open-minded to things like trials, you know, and I know it's a tough time and I know it's a tough diagnosis, but understanding that you hold the secrets. Your DNA holds all
Your
the
body
secrets.
holds the
Your
secret.
The
body,
African
once again,
genome is the oldest genome in the world. We
That's
need
right.
to be understanding it.
the secrets of
Right.
the universe lie
Right.
within us. And if we don't give it up, we're going to get what we've always gotten. So having an open mind about that, or at least take the information and find somebody you can trust. You
And
know,
explain it to you, yeah.
and find a trusted advisor.
Call us. We'll help you. Call
We
us.
cannot afford to stick our heads in the sand. We cannot afford to just call Henrietta Lacks and Tuskegee and say, we're not going to do it.
Right.
Our people, we are dying faster. We are diagnosed later. Every disease, you name it, we're the poster child for just about everything.
Right.
And so we have to step up for ourselves at such a critical time as this, even when we don't feel good, even when we're faced with our mortality. What other time to do it? That's the time.
That's the time. Got to do it.
Reach out, ask us. We're here. We will do
Call
whatever
us,
we can.
email,
and then
text
pull
us.
up seats at the table. Clinical trial design. Don't just design trials and then hand them down to us. How about include us at the table when in trial design, right? In pipeline programs, in research, pull up, like Rihanna said, pull up. You know, there's room at the table. We're not taking seats. We're making the table bigger.
That's
Bring
right.
our own table.
Bring in our own table. Bring in our own table. I want the drug bottle to say, this drug is made for Black women like you, like me, right? I want that drug.
Test it on Black women. How about can we just
At
start
least
there?
do that.
I know, right. We want the drug. So,
Oh my gosh. Thank you.
oh my gosh. Thank you so much. You guys are rock. You guys are so awesome.
My heart is so full.
I know, this was fun. Thank you for having me.
I'm so glad you came. So happy you came. Yeah, we do this every week. It's so much fun, right? It's the best.
Please join us again.
Please
give
come
us
back.
Updates on the research, updates on how you're doing, Doc. You know, let us know what we can do to support you. And we will take questions and we'll circle back to some of those questions in the chat. So
there's a lot of questions here that we can't even begin to answer. We'll try to get the answers, and we'll publish your study, you know, Quita.
Great.
Put it out there and put on our website and stuff so people can see the data, and it's going to just create another study. We have more questions, you know what I mean?
Right.
So let's get the word out on that.
Of people who maybe want to participate in studies. Every trial is not a drug trial. Some trials are exercise, some trials are imaging, some trials are diet and lifestyle and other things. So, you know, keep an open mind to all those things, you know, and Quita collecting that real world data where we don't have to wait 15 years for the results from the trial, you know, is super important. So thank you for the work that you're doing. And
thank you so much for the work you're doing.
Table you built, right? For the table.
That's right.
I know you, girl. I know you go, because what you did at your company is going to open doors for so many people. And so it's going to make, and it's going to be a model for other companies. So you're a rock star, girlfriend, rock star.
And for everybody who feels like you're laboring on these D&I, committees and everything, there is a possibility for you to do the same thing. You know, when that opportunity meets preparedness.
Yeah,
that's right.
It can happen.
Yeah. And Nicole, you're now going to work, girl. You're part of our advocacy team. So we got so much work for you to do, girl. You just watch. I'll call you tomorrow.
People need
To God
to
be
hear
the
that.
glory. So that's all I say. To God be the glory.
Nicole.
Yeah.
Thank you. It's lovely meeting you too, and everybody. Thank you for having me.
Yeah. So
how do we got next week?
Oh my gosh, we have Matthew Knowles.
Oh.
Yep.
And all I really want is a Beyonce tweet. So everybody needs to tweet Beyonce and tell her to watch the show, because her dad's gonna be on
the show.
We're gonna talk about male breast cancer.
Yeah,
and
it's important to know in your family history, not just your mom's side.
Yes,
But it happens on your paternal side, on your father's side,
Yeah.
knowing your family history, getting that genetic test and talking about those secrets. We're only as sick as the secrets we keep.
Yep,
You
yep.
can't
Ooh,
afford
I
to
like that. We're
Yeah.
only as
Use
sick
that
as
one.
the secrets
I'll
we
use that one. I'm
keep.
writing that down.
That
Right,
needs to
right,
go on a
right.
shirt.
Right, right.
love
And
that.
also, Monique, so in October, which starts tomorrow, it's Breast Cancer Action Month,
Right,
not
right.
awareness, Breast Cancer
Yeah.
Action Month. And so
Right.
we actually are going to add a show every week. We're actually going to be on Sundays at 3 and our normal time at Wednesdays at 6. So Sunday, we actually are going to talk about the ABCs of Black breast cancer, kind of the basics, the resources. We have my doc coming on, Regina Hampton, and
Love her.
I love Dr. Regina, and another Dr. Nina Watson, radiologist. We're going to talk about screening, mammography, all the basic things you have to do to know your risks, and then to know what to do if you are diagnosed. So starting Sunday, we'll be on at 3, and then we'll be Wednesday with Matthew Knows. And we have an action-packed October.
Yeah.
So lots of work to do, lots of stuff to talk about. So thank you
Right.
for being with us. We love you guys so much.
Okay.
And so what's your Twitter, everybody? What's your Twitter? How can people reach you?
I don't have a Twitter.
So how can breasties reach you if they got questions? Or
Yeah.
Okay, well, you can reach me at Nicole Edgel. I'm on Facebook. Or you can reach me. My email is edgel_Nicole@yahoo.com.
Great.
My Twitter is execq style, and that's EXECQ style, STYLE on Twitter.
Awesome.
I'm Dr. Monique Gary on the Facebook, the LinkedIn, the Twitter, the YouTube, the Instagram, all the things. And Ricky?
Ricky, I'm Ricky Dub on Twitter and Instagram, but touch BBCA on all the social. We're here, text us, tweet us, whatever. And if you need help, we are here for you. That's our purpose. That's my purpose, to help people. So
This is
let's
true.
do this thing.
She will text me and ask questions on your behalf. She will
At
get
2
you
in the morning,
appointments.
right?
It's okay, but we're here to empower and provide a resource, and so you just know you're not alone. We
Yeah.
want to thank our sponsors, Amgen,
And thank you, and Genentech for sponsoring
Genentech.
October. So thank
Yes.
you, Genentech.
Immunomedic. Thank you,
Yeah.
all the sponsors. But we
Yeah.
hope this has been relatable, reliable, and real. That's what we set out to do: relatable, reliable, and real. So the
Thank
doctor.
you. The
Thank you
doctor's
for
in.
joining us.
Breasty love. Breasty love.
Breasty love.
Take care.
Bye. Bye. Take care. Bye.